Hey, you guys able to hear me now? I think I was having some mic issues. Let me know in the chat. All right, perfect. Fantastic. We'll start in just a few minutes here, just like normal. Thank you all for joining me on this Wednesday afternoon. Hopefully we'll have fewer issues than yesterday, but we'll see. Hope everyone's doing all right today. Not sure what your schedule looks like, but I haven't seen any test announcements to get a haircut. I wish I could get a haircut. I'm too worried about the Rona to go get one. What's up, Abby? I combed it today. That's probably the difference. That might be it. Yeah, someone's like, well, you go to the hospital to work, and but we have like cleaning supplies readily available, and I can reasonably stay 6 feet away from people, but the hair cuttery or wherever, I'm sure they're gonna be right up on me. So I don't know about that. I'll wait. Maybe until I get a ponytail or something. I just bought some headbands, and it has been a new lifestyle for me. So that's my offstage persona. Oh my goodness, Kelly, that's crazy. Yeah, headbands have been keyed past couple of days. Although it's interesting, I saw I didn't read too far into the article. I did see something about hairdressers, and it said there was something like 2 hairdressers who ended up being asymptomatic had tested positive. They wore masks along with their clients, and it said secondary transmission was like almost zero. So, definitely I think masking up is the biggest helper in a lot of that stuff to prevent that transmission. My luck though, I'm over here in Osceola County. It would just be a bunch of people wearing stuff with their mask underneath their nose. Oh my goodness, those kids in your background. Yes, that is my 2.5-year-old. She is at the door, and I'm wondering where my wife is to go and grab her, but she's not screaming and crying, so that's good. This is the first time today she's having a good time, so fortunately, hopefully that'll hold. We have no idea though. All right. Well, it is 12:30, and I have a decent number of people in here. Let's see. So, I did have a question on the sticky board here. Is a question regarding the drug information assignment, and I apologize for that. She's having a great time apparently. Gotta love kids. Anyway, so they're asking about indications for drugs. Talk about off-label uses. You don't. She's not being at the door. Anyway, off-label uses. You don't have to include all of those. It's probably easier to get like specific drug dosing for things that do have labeled uses for it, so like the FDA labeled, indication for like hypertension for something or something like that. You don't have to list every single one of them that are out there, but it can be just kind of feel it out. Just get a couple if that works out for your particular drug there. But anyway, all right. So, this is apropos because we're talking about pediatric and geriatric pharmacology. So, it's good we have the little one making herself well known there. So anyway, so getting into this, let's talk about the geriatrics first. We'll kind of touch on this again when we get into Pharm 2. Yeah, yes, hopefully no more bobby pins Although I'm having trouble finding a couple things, so I'm wondering if she might have eaten those too. So we shall see. But anyway, getting to the geriatrics section here. So let's talk about this. We'll touch on this too when we get into Pharm 2, when we actually have more kind of perspective on the drugs we're talking about. But here I'll just kind of briefly talk about why we look at these populations as sort of being different and why we actually care about talking about them specifically, because they can be quite different. And you'll see this too when you're looking up your drugs for your assignment, how they may say specifically like, okay, well, here's a pediatric dosing section. Like, why is that different than the adults? And why do you make special considerations for elderly patients based off of organ function and things like that? So we'll look at those normal changes that occur from more of like a physiologic standpoint and how that might affect our drugs. Now, certainly these numbers are a little bit outdated, but we know that we're having a greater proportion of elderly patients here. They are getting older. Life expectancy in general is getting better, although who knows with the recent goings on how that's going to be affecting things. But regardless, let's talk about how we like assess these patients for some of these changes that are going on here. And oh my goodness, I forgot to start recording, so I'm going to start recording right now. But anyway, so we're looking at these elderly patients here, and so here's just one example of how we can do an assessment on them. There are many of them that are out there, but I kind of like how using something like this is able to get a pretty sort of holistic approach of looking at the patient. And so we typically are going to find that these elderly patients, they have a lot of complex problems. They have comorbidities, they have multiple medications they're taking. And you can find too a lot of times that they're taking a medication for one condition and it then exacerbates another condition, or it introduces a new side effect that then requires a different medication. And in general, something you'll learn from me is that you never want to treat a side effect with another med if you can. People taking drugs is certainly job security for me in some sense, but in general, fewer drugs are going to be better for these patients here. And we also want to talk about like functional capabilities, right? So it's not just a matter of like looking like what their blood pressure is, but it's more like what can they do, what can they not do. We'll look at those changes over time to see are things improving. Not just the patient giving you a kind of a subjective feeling of if they're improving, but actually looking at hard and fast things like how far can they walk before they get winded, can they perform certain activities that they enjoy, and things like that. And it's really good to take advantage of the interdisciplinary team, and so you're probably going to hear a lot about that from all of your professors, and again, that's why we like to hire people with diverse backgrounds too, right? I mean, I was the first PharmD to work for Nova Orlando, and hopefully the last if I stay here long enough. But we're going to see that by incorporating people like the pharmacist and the nutritionist and the respiratory therapist, and incorporating all these different people, each with their own perspective, you're able to get a better full picture of the patient and sort of what interventions are going to be most have the most utility for your patients there. So, we talk about things like activities of daily living, and these can go from the most basic of things like can they get up and dress themselves and whatnot, all the way up to more intermediate and advanced activities like doing housework and being able to go out and buy their own groceries and things like that. And so you want to look at changes over time in these things, because hopefully, if you have someone who has like chronic pain and they aren't able to go to work, for instance, and we're able to treat that, then functionally they hopefully are getting better such that they can now go to work and be more productive in that sense. But it can even go to other things as well, like looking at things like can they prepare their own meals, can they handle their finances, or do they need someone to come in and actually help them out with that? So starting off, I want to talk about the nutrition section, and you're like, well, you're a pharmacist. What do you care about nutrition? And it turns out it's actually pretty important when it comes to medications, not only just in the physiologic changes you see with people who may have poor nutrition, but you're also going to find out as well with things like, the medications they may be taking and how that affects their nutrition. Like, are they able to eat very well? Are they able to, are they super constipated from the pain medications they're on and things like that? And so some of the reasons why these patients may have inadequate nutrition can include things like their medical conditions. Maybe they have poor dentition, or their dentures are not fitting very well. Not only that, but you can also see many medical conditions, dementia, CHF, and things like that certainly are going to be a big player here. And the other thing too is like you find a lot of medications they may be on tend to exacerbate some of these conditions, and so you may think, for instance, like grandma's just acting a little more forgetful than as of late, and she seems to be just tired all the time. And you may think, well, she's just getting older. Well, sometimes it's related to the medications they're on that are actually making that worse in those situations. But you may also have lack of financial resources and sort of limited access to ability to get food and be able to prepare it for themselves very effectively. So you also want to ask them things like, what kind of food and drink intake are they getting here? And not only that, but you also want to focus on things that are not fully medication related. So things like vitamins and supplements and whatnot. Try to get kind of average amounts that they're getting in on a day-to-day basis there. And so you're going to look for, especially like are certain illnesses or conditions sort of affecting this, or, are their finances affecting this, or they're not getting good intake. Ask about things like, are they getting fiber in their diet? Are they drinking milk? All of these things are important because they certainly can affect their medications, since that's what we're going to focus on. This is important too, talking about things like alcohol. I always make it a point when I'm asking someone how many drinks do they have a day, like ask about how large the drink is, because you can say, oh, I only have, 3 beers a night, but they're one of those big tall boy ones, right? Well, that's a lot more beer than a simple 16-ounce beer sort of thing, or 12-ounce, whatever it happens to be. Or they only have one glass of wine, but that glass happens to be the whole bottle. Okay, well, that's a much different story. So it's important to ask more details about that. And then ask about things like, any dental issues that are affecting their ability to eat, financial resources. A lot of times patients are on very fixed, limited incomes, and you find they have to make decisions like, do I buy my medications for the month, or am I going to have enough money for food, right? We also ask about things like prescription, and you want to make the distinction to ask about OTC meds as well, because a lot of people may not think about, when you ask them the question, well, what medications do you take? They may only think about the prescription ones and not think about all the OTC stuff that they take as well. So you want to ask about that specifically, because that can certainly lead to significant interactions and can definitely cloud the picture there. Asking about weight gain and changes over time, weight gain or loss as the case may be, and then ask about things like, are they physically able to get up and go shop, or can they cook and feed themselves and whatnot. So in terms of laboratory tests, this is where I want to focus a little more time on. So you're doing your Clin Lab course now, so you should be familiar with most of these tests and sort of what they're looking for. Getting a simple CMP on a patient can be quite helpful, because not only will it tell you their basic chemistries, but it can also get into things like getting their GFR down, right? So you can actually calculate their creatinine clearance based off of the Chem 7, which is included in that CMP. Liver function tests are going to be included on there as well, which can help us to determine how well they're going to be metabolizing drugs, because really significant hepatic function or significant hepatic impairment can really limit that in a lot of situations. But also things like, looking at the cholesterol panel, we look at the A1C. If you recall, that's kind of your running average for glucose over the past 3 months or so. It's always interesting when you have diabetic patients and they're non-compliant, and you're pretty sure they're non-compliant based off of some other things you're seeing with the patient, but you get their glucose that day they come in to see you, and the glucose looks fine. You're okay, well, maybe they are taking their meds like they're supposed to, but then you check the A1C and see it's still like 8-9% or something like that, and okay, well, maybe they took their insulin right before they came in to see me, so their glucose would be good, and they think they'd be able to get around having that heart-to-heart talk, but nope, the A1C never lies in that situation there. But looking for things like CBC, so we can see if they're having anemias going on, see what their platelets are doing, white blood cells, all of that. Vitamin B12, which can certainly impact things like on your CBC with your hematocrit and whatnot, and hemoglobin counts. And then sometimes your analysis can also be handy to look at there. So all of that's kind of trying to tell us, like, okay, what kind of changes are we seeing? And one of the big problems you run into with patients who, especially like in long-term care, or patients who are seeing the same provider for many, many years, is you find that they will start them on a medication which is appropriate for them at that time, but then they go on and they're on it for 10, 15, 20 years without really anyone going back and looking to see, well, is that still appropriate for that patient? Maybe they've lost weight and that dose is too much for them now, or maybe their renal function has diminished, maybe their hepatic function has changed, such that you need to go back and readdress that stuff. I cannot tell you how many times I've seen patients, sometimes even in cases where death has occurred because someone never went back and addressed those things. Especially like, if you look at these long-term care facilities, they're not being watched very well, and so it's very easy for patients to go a while without anyone checking in on them. Maybe their fluid intake has been bad and they get dehydrated, and that leads to some pretty significant issues in terms of medication safety, as we'll see in a little bit. But getting into this term called polypharmacy, this is essentially when you have patients who are using 5 or more regular medications. And the reasons for that are, multi-fold. You can see things like just people living longer. The longer you live, the more conditions you sort of rack up over time, which all require their own specific medication therapy. We see more chronic diseases, so it's not uncommon to have patients who have COPD and they have osteoporosis and they have chronic pain and they have, so it just stacks up on itself over a while. And then, if you're practicing evidence-based medicine, which is what we're teaching here, you want to go by your guidelines. And so if your guidelines say, okay, if they've had a previous heart attack, they should be on a beta blocker, an ACE inhibitor, a statin. And then if they have COPD, they need to be on the corticosteroid, and they need to be on this and that. It really stacks up very quickly to where patients can be on a dozen medications, no problem, right? It happens all the time. And so what you can see here is that, as age and comorbidity increase, you're going to see there's a large jump in the number of medications they're going to be taking for each additional disease state. So again, if you imagine someone with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, COPD, they can be on like 12 different meds like 5 times a day. And I mean, I'm a relatively healthy individual and I can barely take a multivitamin 1 time a day. So imagine trying to keep up with this. It probably takes up a significant portion of their day there just to be able to stick with that, right? As I mentioned, evidence-based guidelines will include new medications occasionally, which you'll then have to add on to their list, and hospitalizations too. Most patients who go in for hospitalization will come out with more medications than when they went in. So again, that stacks up after a while. And one of the big problems you're going to run into that you'll see with these sort of chronic patients is that they'll see a lot of different specialists, and this kind of contributes to a lot of the medication errors that occur. But imagine, you are the family practice person seeing them, and you kind of see them longitudinally for the long term, and then they go see a cardiologist. The cardiologist writes for a medication, and then they go see a neurologist for something, and the neurologist writes for a medication. And you seeing that, being the central person, you see, okay, well, I know the cardiologist med interacts with the neurologist med. And so you're thinking, well, something needs to be done about this. But frequently what you're going to find is that a lot of providers don't feel confident in doing that. They don't want to step on anyone's toes. And so they will just leave it alone, right? They'll say, okay, well, go talk to your cardiologist about that. And then the patient never does it. And so you end up with these like really extensive med lists with a lot of duplications, a lot of side effects being incurred here. And no one's really taking the steps to say, hey, wait a second, let's try to coordinate something together and try to see if we can come up with a better plan here. Because again, you just don't want to be that person that stops a med and then they go back to their specialist and you get a phone call, getting an earful of them yelling at you for it. So it's a common issue you're going to run into. So hopefully you will not be those type of providers. You're going to be very confident and very intelligent, and you're going to tell them, no, actually this is what we need to do, and come up with a plan for them. So what are the consequences we're going to see here with these patients? We're going to see adverse drug reactions are going to be much more common, especially as you add on more and more medications. Your risk for reactions happening are just going to increase naturally. And a lot of times what we're going to see is that the mental status can be very much affected by many of these medications. So one of the big things we see is that they have a lot of sedation, they have hypotension, they get lightheaded. There's a lot of falls that are associated with this. And so I'll give you a good example of actually a family member, a distant family member that just happened within the past 6 months or so. And so, we have a family member who is, not too terribly old. I mean, she's, late 50s, so she's not elderly as by this definition here, but she has a lot of chronic medical issues. She's a long-term smoker, long-term drinker, has osteoporosis because she's postmenopausal, has chronic pain issues, and one of the things that was happening with her actually was that she was having significant constipation as a result of all the opioid medications that she was on. And she was actually calling up me and my wife because we're both pharmacists, and they're asking for help. That, man, I need something for this constipation. It's getting so bad. What can I take? Some kind of antispasmodic or something. And we're like, well, when's the last time you've had a bowel movement? She's like 2 weeks ago. And we're like, what? Like, no wonder you're having all these abdominal cramps, because you haven't gone pooping that long? Like, what, let's look at the baseline issue here, right? Well, anyway, along with having all these medical issues and along with having, chronic alcoholism and stuff, like she had electrolyte imbalances. And so what happens one day, she gets a Charlie horse. She stands up to work it out, and guess what? Now she has issues of lightheadedness due to some of the other medication she was on. So she falls. What happens when she falls? Well, then she has a fracture, right? Vertebral fracture, wrist fracture. Now she's on medications in order to manage that, right? So you can see how these things compound on one another very quickly. And she's not even that old, right? So if you have someone who is, in their 70s and 80s, it's very easy to see how these things can snowball over time. So that's a big issue. The other thing, too, is going to be decreased compliance. After a while, patients may just be like, well, I can't afford this stuff, so I'm not going to buy it. Or they may be like, well, I feel worse with the medications than I do without them, so I'm not going to take them. And frequently, you're going to find when patients come to you and they ask you, or you ask them, hey, are you taking the medications like you're supposed to? They're just going to say yes, because of the fact that they don't want to get a talking to. They don't want to feel like they're going to get judged by you if they say, no, I'm not taking my meds like I'm supposed to. So you're thinking, okay, everything is on the level and these meds aren't working, so you increase the dose, right? Like that. And then you end up finding that if they ever do start taking it, then they're taking way too much, right? I remember one time I was during my rotations, and I was basically running this Coumadin clinic under my preceptor, and Coumadin's a blood thinner, and it's one of those things where I had a patient who was particularly difficult to manage. He's an elderly man. He had hepatitis C, he had HIV, and he had a history of AFib requiring. I'll get to just a second, Abby. I'll talk about that. But he required warfarin for his AFib. It's a blood thinner. But the issue is with those type of patients there, especially HIV medications, they cause all kinds of CYP enzyme interactions, right? So he ended up being on medications that was making it very difficult for the warfarin to work. So we kept increasing the dose, and the INR kept coming back normal, right? So we kept increasing the dose, and kept coming back normal. And so I finally had to go to the guy. I was like, listen, like, please tell me if you're not taking this medication, because if you ever do start taking it and you haven't been, you're going to just bleed out because you're on such a high dose. And, he swore up and down, no, he's taking it. And eventually I remember I was on that rotation for 2 months, and I was seeing him like every week. And then finally by the last week, I finally got him in a therapeutic range. So I said, you know what? That's a good note to end on there. So hopefully he's doing well. But that was one of those things where patients oftentimes will just lie straight to your face, and that's just something you have to be aware of. So Abby asked, you can't do a blood test to see if the drug is in the blood. Frequently, no, you can't. There's not a lot of you can't just do a blood test for every single med that's out there. You theoretically could, but it's expensive, or it's a send out and things like that. So there's a panel of things you can get really easy. For instance, with like warfarin, I could do a PTINR. That's how you check to see if it's actually being effective or not. With some drugs, you'll get specific levels on, but the vast majority of things out there, it's not feasible to go ahead and get a level on. So a lot of times we are relying on the patient being honest with us and telling us if they're being compliant or not. But sometimes, we may see. He says, also if a patient is less compliant, then wouldn't they in reality not be taking all these meds regardless of family provider not wanting to step on anyone's toes? It depends. You may have people who are taking the stuff religiously, right? So you may have people who are being very compliant with their stuff. It's not that everyone is non-compliant. It's just that you end up seeing, in general, there's going to be some percentage of patients who are non-compliant. And it can be to varying degrees. It could be someone who's only taking doses every other day because that's all they can afford. They want to make it last for longer. So there's a million different flavors from that standpoint there that can come about here. But it's funny too, because like we'll have cases when we'll have patients who will come in to the ER and they're actively seizing, and we'll say, well, what medications are they on? The family's like, okay, they take phenytoin, like a lot of anti-epileptics you can get levels on, and we'll do a level and it's completely negative. So it's just like, okay, well, no wonder they're seizing. So that way we know, okay, we'll go ahead and load them up with that and stop the seizure there. But sometimes they are being compliant and they're just still having seizures. So sometimes it's just an inefficacy of the drug that can pop up here. Shelby's saying, when I worked in as an RD in the hospital, everyone said they ate super healthy, but they were like 300 pounds on the A1C of 13. Absolutely. It's like, yeah, I eat like, salads, and they're just like, it's like 90% blue cheese dressing or ranch dressing with like 2 greens in it or something. But yeah, I eat salads every single day, No, it's just one of those things. Broccoli and chicken every single day. Yeah. Um, it's just one of those things where it's just that you got to understand some people are not going to be super honest with you all the time. So, it is what it is, right? Um, Anyway, so looking at decreased compliance, again, other reasons for this include sort of like they're just on so many medications, it's hard to keep track of. The complex dosing schedules, if you're taking things multiple times a day. So some things we can do to help with this include like, using combination drugs. So that way you get multiples into one. I always go back to HIV for this example, because with HIV, I mean, back in like the 90s, they were taking like medications like all around the clock, and the pill burden was just exceptional in terms of how many medications they're taking. And then all of a sudden, like nowadays, we have like pills you can take one time a day. It's just one pill, one time a day, and you get your entire HIV regimen. So things do improve from some of those cases there. But again, it may depend on things like the economics of it as well. Can they even afford that combo med when the separate ones by themselves are going to be cheaper potentially? So yeah, Aaron's saying how much broccoli and chicken can make a difference too, right? And so I mean, like, and you can't eat chicken without like it smothered in honey mustard, right? Like, what's the point of even living, right? If you can't do that, but anyway, so and then looking at things like support structures, if they have someone there who can help keep them accountable for that sort of thing can be important. Mental decline is going to be important too. I cannot tell you, as part of my fellowship when I did it for 2 years at the Poison Center up in Jacksonville, we would basically my staffing time, so to speak, was in the Poison Center actually taking calls, and so I was actually taking calls from all these lay people who said, and I cannot tell you how many calls you get from elderly patients who forgot that they take their first dose and they just went ahead and took a second dose. Most of the time it wasn't an issue, but in some cases it could be a really big problem, especially like heart medications and things like that. Visual impairment can be a big problem. Prescription labeling on bottles is relatively small font, and so you can have a lot of issues with visual impairment, even seeing is it the right drug, the right dose, etc. In that same community pharmacy rotation I did where I ran that Coumadin clinic, there's also a retail pharmacy side of it as well that I was working in. And I had this one lady that came up, and I swear she was on 12 different medications, and she's coming to refill all of them at the same time, as I do. And I mean, you can tell she cannot see. Yeah, she's blind as a bat, right? So barely can see more than a foot in front of her. And what was interesting is she said, "Hey, can you take all the caps off my old bottles and put them on the new bottles?" And so I was looking at the caps on the old ones, and like on one of them it'd be like a big red triangle, and then one there'd be like a purple circle. And I say, "Oh, like what's all these markings here?" She's like, "Well, I can't really see, so that's how I, know what the difference is between them." And I was like, "There's no way you remember every single one of these different ones. There's like 12 different medications here, right?" And so she actually went through and she was like, "Well, you can quiz me." So I quizzed her, and by golly, she knew every single one of them. So I said, "Okay, yeah, absolutely, that's fantastic." So sometimes you'll have a visual impairment, but their minds are still sharp as tack. So it just depends on the person there. Amber's asking, like, do large print labels exist? It depends on the pharmacy. Sometimes it can be difficult to get all that information that like legally we're required to have on there on those labels. So in some cases we may have to sort of use less text in order to get that there, and frequently we'll give them like printouts and things that also will have large text information there. Kelly was saying, I worked in EMS and many patients have no idea what they're taking. Like they don't have the med list but a giant bin full of meds. Yeah, that's really important to consider. We would do in school, we would do what we call brown bag events. We would go to local nursing homes and we would basically say, have all the residents come out, and they all had a brown bag that had all their medications in it. And I mean, they would just dump out stuff that was like from the 80s practically, or they would have the same medication in 2 bottles but of different sizes. That little white pill they're taking, or take that little blue pill. But they would have stuff, and I'm like, well, how long have you been? How long? Did the doctor tell you to stop taking it? And they're like, yeah. They said, don't take this one anymore. I was like, why do you still have it? Well, you never know. I might need it later on, right? So they tend to have a little bit of hoarding that goes on there, and they keep stuff around for a long time. Stuff that's expired, stuff that's that is antagonistic to other stuff they're taking. It was crazy. So we'd basically go through and try to pare down their list and say, okay, when you go back to your doctor, here's the things you should ask them about, etc. And that was able to try to pare down that list and make that brown bag a little bit smaller for them in the future. Other things too, they decrease swallowing ability. So think about patients, especially like Parkinson's disease. I think a lot about. We actually have a program This is pre-COVID time. We're still trying to do it now, but there's actually we have a speech language pathology program in campus in Orlando, and so we've joined up with them to actually have a few talks talking to Parkinson's patients, and that's actually been really neat to actually see and talk to those patients. But one of the things you'll find is they have decreased swallowing ability of dysphagia, and so you can give them a tablet, but they can't swallow it, right? So you have to consider, well, do I have the ability to switch this over to a liquid formulation, right? So those are things you want to consider. In the hospital side, a lot of these patients will be frequent flyers. It may be very difficult to get venous access on them, so getting an IV dose of something may not just be as simple as saying, hey, nurse, get that IV. There could be a delay there. And then are they even willing to stick with treatment, right? Sometimes they're at the end of their life and they're just like, nah, I'm good, right? Or they don't like the way the medications make them feel, or whatever the case may be. They may just not be ready for that, right? And so that's when you start to talk about things like end of life, and we start talking about things like palliative care and whatnot. Typically, if we're thinking they have less than 6 months to live, this is where we start to consider looking at these things. So, for instance, here when you're looking at this graph, looking at the idea of life extension, so the quantity of life, and then switching over to more palliative treatment later on, you're going to get closer to just really focusing on this, where you're looking more at the quality of life they're experiencing. And so frequently we would have my wife, she actually did her second year residency in the VA at Gainesville, and it was just specifically on pain management and palliative care. So she was basically helping to manage the pain medication regimens for these veterans and whatnot. And one of the things that's really interesting too is you see these patients that are like in stage COPD. They are just gasping for air, like they just have such bad dyspnea from all of that. Even at baseline, they're not even moving around. And so one of the things they would do to try to focus not necessarily on the quantity but the quality of life is they would use pretty hefty doses of opioids, because it would help to blunt that respiratory drive just enough to where they would be comfortable, and they wouldn't sit there be basically slowly suffocating to death. And again, it's one of those things where like, yeah, you're not going to get them to live any longer because of that, but they're going to be a heck of a lot more comfortable. And so that's one of the focuses you'll see there with more palliative care and treatment. And then obviously you're focusing on the family after the patient passes, and that you may be that continuing person where you're seeing multiple generations in the same family, especially like in a family practice and whatnot. So let's talk about the physiology of some of the actual physical changes that occur in these patients here. So in terms of cardiac function, you're going to see pretty expected things. So things like higher blood pressure, you're going to see more left ventricular impedance, you're going to see reduced heart rate. In terms of kidneys, this is another thing that you really want to focus on because you're going to expect to see these changes. So things like decrease in GFR, right? We know that's kind of a direct effect on how we clear and excrete many medications. Not only that, but then also acid-base balance is going to be difficult to control too. And so you tend to find that like younger patients, they may be able to handle an acidosis more easily because their body has a lot more sort of capacity to handle those changes, as opposed to an elderly patient who, once they start to go acidotic, they don't really have the means of actually controlling that very well, either from the respiratory center or from the urinary center, right? So this two issues you're going to run into with the elderly patients in terms of acid-base status and GFR going down pretty significantly. And again, even you can see here that we're going to see a steady decline in all of these functions here. Even those of us that have unfortunately already hit the 30 mark are already seeing their cardiac function or actual maximal breathing capacities going down. Not to say anything of how COVID might be affecting this, right? But let's look at some other changes. In terms of the GI tract, you tend to find that things are slower, but you will still find for the most part that absorption is going to be pretty complete. There are going to be some exceptions to that though, but overall you're going to see decreased motility, you're going to see slightly decreased absorption, all of that, decreased gastric emptying time. Things are just kind of slowing down, right? You're also going to see, when we include the liver in this, you're going to see decreased blood flow, which can actually help to decrease that metabolism. If you're not taking that blood and presenting it to the liver to metabolize those drugs, then yeah, things are going to not be metabolized as quickly, right? And so ultimately you don't see a lot of major changes in absorption, but you're going to start to see more and more drug interactions that can occur here. So for instance, if patients are elderly and they're worried about osteoporosis, they're more likely to be drinking lots of milk, right? And so milk has calcium in it, which is good for them, fortified with vitamin D and all that good stuff. But then you can see that it could potentially bind up other medications, or that milk tends to be constipating, right? And so these are common things you're going to run into with these elderly patients. Diabetics you're going to typically see too. They can develop gastroparesis, We actually have slowed emptying of the GI tract as well, and that can impair some degree of absorption. But let's talk about drug distribution. This is going to be much more important in terms of changes you're going to see. So, and if you recall, we're going to see that certain changes in VD can have big effects in terms of clearance, right? We saw that as volume distribution increases, we typically see the half-life also is going to increase as well, right? Because it's more volume essentially you're having to clear from the kidneys or the liver or wherever the case may be. And so typically you're going to have reduced lean body mass. So you can typically see the muscle mass is going to go down, even though adipose tissue percentage is going to go up. And you kind of see this between like a 20 to 30 year old versus a 60 to 80 year old. You can see the body water percentage is going to go down, which means you might get like a concentrating effect in terms of volume distribution for like a hydrophilic medication. But on the flip side here, you're going to have a much higher body fat percentage of adipose tissue. And so that can then lead to lipophilic medications have a much higher volume distribution. And so you can see this too when you're looking at these changes in Lexicomp and other drug references when they're saying like how to dose these like for elderly patients. You might see that it's either higher or lower dose based on some of these body changes that are typical in this sort of population here. Other things include like decreases in serum albumin. This is really important too for distribution for drugs that are highly protein bound to albumin. If I have a decrease in the amount of albumin I have here, that means more of that drug is going to be free to distribute out into the tissues. And so you can see that may increase VD as well, right? Hepatic blood flow is going to go down, kidney weight is going to go down, all of which is going to be slowing down our metabolism as well, right? So as I mentioned, that protein binding is not only just a feature of just age, but you're also going to see the nutritional status is going to be playing a role here too. You see patients that are chronically malnourished are going to end up developing lower albumin levels, and that can end up leading to significant changes in distribution. And not only that, but also the actual pharmacologic effect, because if you recall last time, I think we said that the free fraction of the drug is what's actually going to be pharmacologically active. Brian's asking, do elderly patients feel cold more often due to the decrease in cardiac output, or is it something else? Now, you do tend to find a lot more cold intolerance. That's actually how the first way that I really knew my parents were getting old, because I went back home one time and I was just like, why is it like 78 degrees in the house? Like I'm sweating buckets here. And they're like, oh, it's nice. So the heat intolerance may not necessarily be cardiac output wise. Some of it has more due to like some of the thermo control that they have in terms of being able to dissipate heat very well. There's some other features that go into it. Some of it may be related to body composition changes as well. But I'm sure there's probably an up-to-date article, if I had to guess, out there talking about some more of that. But it's probably a complicated interplay of different things there. So, but getting into looking at this, so imagine too, let's look at the drug phenytoin. I talked about that previously. Phenytoin is a drug that is used to treat seizures pretty frequently. And so you can see here that if you were to look at phenytoin, let's say we have normally phenytoin is going to be 90% protein bound. So let's say here's our total level of the drug. Like 10% of it's going to be free, which can interact with the CNS to cause its effect, and then 90% of it's going to be bound to albumin, right? But what would happen if our albumin levels drop and there's less of it to be able to actually bind to the phenytoin? So what you end up finding is that instead of having 90% of it being protein bound, now all of a sudden maybe it's only like 70%, and now you have this 30% that is going to be, and again, my art is beyond reproach, so just be glad that you get to actually see how great my art skills are. Or these are ugly carrots, however you want to look at it. But notice here that if you have a lower albumin level, you now have a higher free fraction of the amount of drug. If I did a blood level of the drug, it would look identical because the actual levels haven't changed at all. It's just that free fraction of it, and that can lead to some pretty significant increased effect, such that they are now more ataxic, they're more dizzy, they're more likely to develop falls and then fractures. So this is why we want to look at things like serum albumin levels and make sure we're adjusting our dose to account for these sort of things. That's just one example with that drug phenytoin that I mentioned. So this is absolutely critical. You got to look at this stuff when you're having patients, especially like up in the ICUs in the hospitals. Kidney function is going to go down, and it is they have less capacity to really adjust for different hemodynamic things that are going on with them, right? So with a young person, if they lose some blood or they have low blood volume, their kidneys can still compensate for that. They have very good compensatory mechanisms. You start to lose that with elderly patients, to where even small changes in blood volume or changes in blood pressure can cause major decreases in the amount of blood going to the kidneys, and thus decreases in GFR. And we know the GFR is going to be our means of actually filtering drugs, and if you can't filter drugs, they're going to stick around for longer, right? And so not only that too, but it also gets a little confusing, because when you look at things like serum creatinine, which if you recall, we were using that to be our sort of surrogate to get creatinine clearance, which was our surrogate for GFR. Well, we mentioned earlier that patients that are elderly don't have as much muscle mass, right? So muscle mass goes down, they have less muscle to produce creatinine. So you can find these like 90-year-old, 100-pound elderly women who have no muscle mass and their creatinine's like 0.9. And you're like, okay, well, 0.9 is normal. She must have good working kidneys. Well, it's like, no, she just has no muscle mass left to produce any. Like, normally, if she had a normal body composition, it'd probably be close to like 3 or something, right? So you can't always take that for granted. You have to consider the patient's whole clinical condition before you can just look at a number and say, okay, well, this is the renal function, right? So one of the things you'll hear a lot, if you've not heard it yet, is you want to treat the patient and not the number. You can't just look at the number and say, okay, we're good to go. You got to look at more than that. Not only that, but imagine, I don't know if I mentioned this previously, but like one of the things you'll see with diabetic patients, especially type 2 diabetics, is that they develop diabetic nephropathy, right? So they will naturally, over time, lose kidney function as a result of uncontrolled type 2 diabetes, right? Also, one of the things you can see with them, if they have diabetic ulcers and things like that, is they may have an amputation as a result of their poorly controlled diabetes. Well, what happens if you have an amputation? Well, that's muscle that's lost there. So that's another means of having diabetic patients who have an underestimated, or you're overestimating their renal function because their serum creatinine is lower than what it should be because they lost that extra muscle from that part of the leg that was removed. So all that goes in to show you is that, you want to be cautious and not just look at this number, but also think about it. Like if I have a diabetic patient who is so poorly controlled they haven't had an amputation, there's no way his kidney function is going to be completely normal, right? So that's one of those things you really got to be cautious with. And two, you can see that even from day to day, renal function can change greatly, especially if they are, sick, they're in the ICU, they have maybe a UTI that turned into sepsis or whatever, that you can find renal function will change from day to day, hour to hour even, and that can directly affect your drugs. And so anytime I would do like an ICU rotation, either in fellowship or in school, is that we would always make sure we go through, readdress the renal function, and see if we need to change any of their medications to address for that, right? To make sure we don't need to give a smaller dose, or we need to give it less frequently, or whatever the case may be. So really, really important that you address that, because you can see increased half-life of the drugs. They're sticking around for longer. You can see increased risk for having those toxic, really high concentrations. And hydration status is so important here. As I mentioned previously, you want to make sure patients are well hydrated, but frequently, if they're not being watched very frequently, if they're in the nursing homes or something, they can go days without getting much hydration, and they come into you and they're hypotensive and their drug levels are super high because they're all concentrating in the blood there, and it can lead to some very significant effects. I had one case where this elderly woman was coming from the nursing home with seizures, and she had a history of COPD, and she was treated with a drug called theophylline. Theophylline's like a super old school drug that you'll probably never use in your days. We'll talk about it briefly because you still might see it being used, but she'd probably been on for like 20, 25 years. And no one really ever went back and checked her renal function to see if her dose was still appropriate or not. So she was on this drug for a long time, and then something happened. She got a cold or something. She stopped drinking, and then that led to those levels of the drug getting super elevated. And then she started seizing. She came in. Ended up being, even after we got the seizures under control, we actually did an EEG. Now she's in what they call non-convulsive status epilepticus because the brain levels are just so high. There's basically nothing we can do for her, and she died from that. So this is, again, why if you're taking care of patients over the long term, you want to make sure and go back and check these things out on a regular basis. So just to show you again that Cockcroft-Gault equation and how these things can play a role here, right? We know as age goes up, this difference is going to get smaller and smaller, so that we know that's going to cause a proportional decrease in creatinine clearance as age goes up. I guess that would be an inversely proportional relationship, but basically off the math here, you can see as age goes up, creatinine clearance goes down. Same thing with serum creatinine here, right? But this may not be entirely accurate, right? Always take it with a grain of salt, especially in as the older your patients get there, right? So anyway, so we kind of know what those variables are doing for us in terms of elimination there. So other things you can see, as I mentioned, drug clearance can be limited. This is going to be less of a factor than what you might see with renal function in terms of actually having to make drug changes or dosing changes for that, but still good to look at, and you'll see that in your drug references if it's appropriate to modify drug dosing based on might be on Child-Pugh score, or might be on several things there. But overall, you may see decreased first pass metabolism. You may see increased bioavailability because some of your enzyme systems are slowing down a little bit. It just depends on the drug. This is going to be, again, less clinically significant unless they have really, really significant hepatic impairment. So it just depends on the situation. So, and again, you think about like the pharmacodynamic changes, right? So like, are geriatric patients more sensitive to drugs? Well, not necessarily. A lot of it could be related to the pharmacokinetics. So that way that you may be giving an adult dose to an elderly patient and they find that, wow, they're just way more sensitive to that drug, but maybe they couldn't clear it as well. Maybe their half-life is longer and the drug is sticking around more. That could be playing a role there too, right? They also have lessened homeostatic responses, right? So imagine you as being young, healthy individuals, you can go from a sitting to standing position and you don't get dizzy and pass out and break a hip, right? Elderly patients do that because they don't really have the same means of actually being able to do things like account for changes in blood pressure and whatnot. Especially too if you're giving the medications that help to prevent that. So, if I give you something that's an antihypertensive and that lowers blood pressure, and then they stand up and the orthostatic hypotension is just much more of a risk for those elderly patients than it would be for someone who's younger and has more of that hemodynamic response that is available, right? So issues of cardiac output, postural hypotension, all of that's important here. Here's again, the temperature regulation we mentioned. They just have less of the ability to sort of account for changes in temperature. So normally cold intolerance is something you're going to see pretty commonly there. And then, of course, fasting blood glucose goes up over time, generally due to insulin resistance and things like that. So let's talk about a few specific drug class examples. I'm not going to expect you to know every single one of these, but I just want to give you a few examples of how this can cause some issues for your patients. And so frequently what you're going to find, as a general rule, it's going to be mainly cardiac meds are going to be some of the biggest offenders here in terms of causing significant adverse drug reactions for elderly patients, and it's going to be CNS active medications, so heart medications and head medications essentially, right? So what we end up finding is that for things like sedative hypnotic agents, these are things that are used to help treat anxiety. These are things used to treat sleep disorders and whatnot. These, if you ever heard of like the benzos or ever heard of like Xanax, that's what is in this category here. And what you can end up finding is that for certain ones of them, they can have half-lives that are extended by 50 to 150%. So they're just sticking around for a lot longer, right? And if you just want to use something for like a sleep disorder and go to sleep, and then it's lasting all the way through the morning, you're going to have a lot of daytime grogginess that's going to be sticking around there. Not only that, but you also have accumulation of things like active metabolites. These are metabolites that still retain the capabilities of the parent compound even after they've been metabolized, right? They come out and they're still active and they have to undergo further metabolism to get deactivated. So if you have not only accumulation of the parent drug, but then accumulation of active metabolites, you see that's very synergistic. You can run into a lot of issues here. So huge risk for ataxia, falls, and altered mental status. Again, it's thing where, man, grandpa's just acting a little funny nowadays. Maybe he's just getting dementia. No, it could be related to the medications he's taking, right? Opioids too, and again, this is a common offender. You're going to see both of these medication classes put together here, and I cannot tell you how many patients. It's actually a trifecta, and it's usually a sedative hypnotic, like a benzodiazepine. It's going to be an opioid, and it's going to be a muscle relaxant, all of which are very sedating, and when used together, it is like just super sedating. I mean, I can't even explain it to you, just because you have patients that have to be intubated because they're so sedate from this combo that they'll be put on with seemingly good intentions from the providers, but not realizing that maybe multiple providers are doing this or whatever the case may be, but it's just too much for these patients. So they tend to be a little more susceptible to things like the respiratory depressant effects, and again, they accumulate as active metabolites. So, for example, you could use something like morphine for elderly patients, but they end up building up an active metabolite of morphine that sticks around for a lot longer and can increase these risks of respiratory depressant effects there, right? And again, these two are synergistic together. So, if you're using a benzo plus an opioid, you're just going to see much more risk for all these adverse reactions. And so, sometimes what we can do is select drugs more intelligently and be more smart about how we're going to do that. Be more smart, which is the way to say that. Be more intelligent and say basically, okay, well, I'm going to use a drug that doesn't have a long half-life, or I'm going to use a drug that doesn't have active metabolites, and you can get around some of this. Or I can use an analgesic that doesn't have the active metabolites and avoid that accumulation. So you'll learn about that later on as we get into the specific drugs of which ones are better for elderly patients based on these different sort of kinetic and dynamic factors that we will talk about. Antipsychotics and antidepressants are another big one. Very frequently, elderly patients are not being treated for their depression. Nowadays, it's getting better, but we're going to see that, especially certain drugs like lithium. We use lithium for bipolar disorder. That one is entirely renally dependent in terms of its elimination, and if a patient has a decrease in renal function, they're going to accumulate a lot of this stuff, and that can lead to pretty significant seizures and other issues. Now on the test, I'm probably not going to ask you specific drug classes because we haven't really covered these in earnest yet. I'm really mentioning these now, so I want you to kind of prick your ears up whenever you hear us talk about these in later semesters, right? So that we can be, oh yeah, I remember him talking about antidepressants and some of the risks in elderly patients. So this is kind of what I want you to take away from this. The other stuff where we talked about changes in kinetic functions and change in dynamic factors, that's stuff you do want to know. Those are the conceptual things I want you to take away from this. But antidepressants, these have gotten better nowadays because we used to have older school drugs like our TCAs or tricyclic antidepressants, and they had just huge risk for things like ultramentation and falls. Nowadays, we have like our SSRIs, like your Prozacs and Lexapros, and they tend to have a much safer profile. So in some cases, for elderly patients, it's better to use a whole new drug class, which has better safety features than something older. The downside for that, though, is that maybe some of these newer agents are more expensive, and so the patient can't afford them. If they can't afford it, then they're not going to take it. So it's kind of a double-edged sword you have to consider depending on the class of drugs we're dealing with. So in terms of antihypertensives, these are going to be really bad for orthostatic hypotension. Not only that, but if they're on diuretics, that can cause all kinds of electrolyte imbalances leading to arrhythmias potentially, so you got to watch out for that. Antiarrhythmics, so things that are treating dysrhythmias, are also going to be another big one too, where they can have issues of electrolyte imbalances. They can have extended half-lives of many of these drugs, which we'll talk about later on, and just that poor hemodynamic reserve. If they have any kind of issues in terms of arrhythmia, they're much more likely to have syncopal episodes and falls and fractures and all the things that go along with that. I actually had a patient, my wife had a patient just recently who was on an antiarrhythmic, and one of the things you'll learn about with torsades, de pointes is a particular type of ventricular arrhythmia that is caused by prolonged QTC. And so there's a certain antiarrhythmic we give that specifically prolongs the QTC, but you don't want to use it with other drugs that affect things like magnesium and calcium and things like that. And so anyway, she had a patient that had actually come in for a syncopal episode, couldn't figure out why it was, but they were on this drug that prolonged the QTC. They're also on a whole bunch of diuretics, which was a contraindication. And then the doc who was admitting the patient said, yep, continue all home meds. It didn't really take a second to say, well, wait a second, let's look at the labs here. Let's look to see what is going on here, that maybe the diuretics is what precipitated the bout of syncopal episode due to the arrhythmia, right? So these are things that we have to call on as pharmacists to make sure that, like, hey, are you sure you really want to do this? Because maybe this is the issue that's cropping up here, right? So anyway, when looking at adverse reactions, you want to make sure that you keep in mind that as you increase the number of drugs they're on, you're going to see an increase in adverse drug reactions. So with like a single med, maybe you have like a 10% risk. By the time you get up to 10 meds, it's going to be like very close to 100%. They're going to have some sort of issue. And frequently, they may not know that that is an issue, that they are experiencing an adverse drug reaction, mainly because of the fact that they just think, oh, well, this is just life now. Right? That this is just, that pain that I'm having now, that's just normal, right? Or, but unless you educate them on what to look for and what to expect in terms of adverse drug reactions, they may not be able to tell you. You ask them, well, are you having any problems with your meds? And they're like, no, not that I know of, not realizing they actually are, right? Not only that, especially if you take into account OTC and herbal medications, these can have really dramatic effects on their prescription drugs. And a lot of times people have a hard time owning up to taking herbal medications because they don't want to get that feeling of judgment from the providers, thinking, oh, these are all just a hoax, and oh, they don't work, and why are you wasting your money on that? So unless you ask them specifically, they may not bring it up. And even though these can have very powerful effects, I'm not here to say that herbals don't work, because some of them really do, and they can really have some powerful effects, especially with drug interactions with prescription drugs. I had one lady who came in for stroke-like symptoms to the ER, and she had been on warfarin, which is a blood thinner, as I mentioned, for her AFib. She's elderly, her memory's starting to go. So what do you take herbal-wise for your memory? We take ginkgo biloba, right? So she ended up taking ginkgo biloba, not realizing that, and no one told her this, or no one asked her about this, whatever the case may be, not realizing that ginkgo actually has some anticoagulant effects itself. So when they got the CT back, what did they see? Well, they saw a big old brain full of blood, basically, because she had a hemorrhagic stroke due to this combination of warfarin plus this ginkgo, right? She had a therapeutic INR, but the ginkgo had such tremendous effects on top of that she ended up bleeding out and dying from that, right? So this is why we ask. This is why you got to make sure you're asking from a non-judgmental sort of standpoint, saying, hey, you know what? Herbals do work. They work for certain things. They could be really helpful for certain conditions. Like, hey, do you take any? And that may help you to open them up a little bit, to be more honest with you. So we may see that in some cases drug reactions are occurring due to prescriber errors. So maybe we're not taking into account some of these changes that occur with patients. Some of it is related to compliance errors by patients. You may find that they're taking their normal meds, and then they develop a cold or something, or an infection, and Ethel down the road, her neighbor, has some extra Cipro from her previous infection. She can let you use some if you want, and then now we have compliance errors, right? They're taking things they shouldn't be taking. Things like that happen quite frequently. And not only that, but seeing multiple providers, right? So if they're seeing a cardiologist, a neurologist, a pain management doc, they're seeing a rheumatologist, they stack up very quickly. And again, no one wants to step on each other's toes here. And then sometimes patients may not even recognize a drug product as a medicine. So there's something here. And some of you, what I found over the years is that people from up north don't really know what these are. But if you're from down south here, you have a pretty good idea of BC powders and goodies. Basically, these are powdered aspirin products that come in these little wax paper sachets that you can then open up into a glass of water or something, and then take that. And they market it for headaches and whatnot. A lot of people don't realize it's aspirin. These patients don't, at least. And so actually I had one guy who had come into the ER, basically had a history history of stable angina, but someone had told him, hey, anytime that you have chest pain, go ahead and take one of these goodies powders, right? So it really wasn't all that well managed, and so he was having a lot of bouts of chest pain throughout the day. So he had chest pain, would take a goodies. Had chest pain, take a goodies. Had chest pain, take a goodies. Finally, he's like, man, this chest pain is not going to go away. I got to go call 911. So calls 911. EMS gets there, and they go, sir, have you taken any aspirin today? And he goes, nope. They don't ask him, have you had any goodies, BC powder? So he says, nope, I've not had any aspirin. So he goes ahead and they give him an aspirin. He didn't realize he got an aspirin, though. And so then he gets into the ER, and the resident comes up and he goes, hey, have you had any aspirin today for your chest pain? He goes, nope. So then he got another dose of aspirin. So now not only are we dealing with a patient who's having a possible MI, now we're also dealing with salicylate toxicity. And all of a sudden he's like, what? I got this ringing in my ear. I can't really hear so good. And he's sweating, and he's, tachypnic. And we realize, we should probably do an aspirin level on this guy. And so not only was it the MI we had to deal with, but now this mild salicylate toxicity on top of that. So again, all that was related to the fact he just didn't know what he was taking at the time, which is not all that uncommon. So what can we do? Basically, we want to have sort of a structured ways of asking about medications. You're going to be learning this in other classes as well, but these are things that I think are important to focus on. So again, are you using the drug as prescribed? And if you go asking yes/no questions will only get you so far, because you only get a yes/no back, right? So if you ask hey, how do you take your medications? That can sometimes uncover a lot of issues where they may have a misunderstanding of what they should be doing. Ask about side effects and be specific. Which ones do you expect them to have, and ask about it. If they're taking opioids, are they experiencing constipation, right? If they are taking a blood pressure medication, are they feeling dizzy when they stand up? These are things you want to be more focused in terms of narrowing it and to see if they're having this issue. If they're deviating from their medication regimens or not taking them at all, why? Right? Is it a cost thing? Is it something you could switch out for a cheaper med? Are you taking any meds not on this list? Are they ordering things online? Are they taking stuff from friends, family members, things like that? And are you using non-prescription drugs? Make sure you ask this specifically apart from just the prescription ones, because again, many people may not think about these on their medication list. Oh yeah, well, I do take ibuprofen for headaches every once in a while, or I do take Benadryl when I'm having allergies. All of that can be playing a role in their total medication regimens, right? Are they using homeopathic drugs, herbal medications, or vitamins for the reasons I mentioned previously? As I mentioned, asking about family members and friends getting drugs. Are they getting stuff from outside of the U.S.? We consider these to be illegal because they're being trafficked in, but doesn't mean that's bad. If that's the only way they can afford their insulin is to get it from Canada, then, well, that might be reasonable, right? Just depends on the situation, but you at least want to know about it, right? Are you taking drugs that are no longer prescribed? And then when's the last time you checked the expiration date? I'll have more to talk about expiration dates later on. Most of them are actually bogus, but there are some notable exceptions to that. But we'll talk about that a little bit later. Ask about things like, are they taking meds independently, or is someone helping them? And if so, who is helping them? Do they at-home nursing care? Are they using some kind of dosage system to help them remember to take their medications, or are they using devices to help them get the right medication amount if maybe they're taking liquids or something? Talking about problems. Inhalation therapy, this is huge because so many patients have issues using good technique. We had that gift from a couple of lectures back there, the lady who's spritzing her albuterol onto her neck there. But yeah, that could be an issue. If someone has rheumatoid arthritis and they have joint disfigurement in the hands, they may not have the dexterity to even be able to use an inhaler appropriately. So maybe switching them over to a nebulizer is better, right? Eye drops, we'll talk more about those next semester when we get into the ophthalmology section. And then what do you do if they forget to take a dose, right? Do they double up? Is that appropriate for the drug? It may or may not be. Things like that are going to be really important to ask too. And then, what other comments, questions they have, etc. And so here's some means of patients helping to remind them to take certain medications. These are terrible from a poison control standpoint because I cannot tell you how many times I got calls. Parents would call up. They took little Johnny or Jenny over to grandparents' house and they got into one of these. And they're like, okay, well, we're missing Wednesday and Tuesday, and then Friday morning is missing. And I'm just like, trying to figure out what the kids actually got into. It can be quite difficult with these, but they can be useful for the elderly patients. Just make sure you tell them to lock that stuff up when the little ones are around. So other things to consider too, with medication expenses, just try to use something cheap. Use something cheap, simple, tried and true if need be. If ibuprofen is going to work, go with it. It's fine. You may have the drug reps coming by saying, yeah, our stuff is the best drug in the whole wide world. But if your patients can't afford it, they're not going to use it, right? And getting patients started on samples can be dangerous because if they don't have a steady supply of those samples and they run out and then they can't afford to get that prescription filled, then that's not great for them either from the long term, right? Watch out for doses of medications that have mixed dosing intervals, so that way they're not taking something Q6 hours and one thing Q8 hours where nothing's really lining up. That can be a difficulty thing with compliance standpoints. And then you always want to consider intelligent non-compliance, or patients on purpose doing something that they're not supposed to, but then not telling you about it. So if they can't afford the meds and they're taking it every other day to make it last longer, that's one thing. If they're taking more of the medication than they're supposed to because it makes them feel good, that could be another problem too, right? Kind of goes either way there. And then also look into whether the patient can physically take the drug. Consider, do you need to look into doing things that are liquid medications? There's a lot of drugs for osteoporosis that the patient can't sit up and sit up for 30 minutes straight. Then there's a lot of medications they can't use potentially from that standpoint. They may have to use an IV formulation as an alternative. So we'll get into all these examples later on. So don't you worry, we'll get into that more extensively. So any questions on that? In the meantime, let me see if there's anything on the sticky board. Okay, so someone asked over here on the sticky board, they said, so decreased muscle mass leads to increased serum creatinine. No, decreased muscle mass leads to decreased serum creatinine because they have less muscle to produce the creatinine. The problem comes into is that when you have patients who have less muscle mass, but they also have worsened kidney function, you may not find that you're going to get that same rise in creatinine. So if you were to imagine looking at somebody, so we have looking at example here. If you're looking at someone with, if you're looking at basically a graph of looking at renal function versus creatinine, serum creatinine levels, you'd find that basically you'd have this inverse line here. You may find, trying to think of the best way to organize this. So maybe this is like serum creatinine, and then this would be renal function, right? We'll call it Rx function. So as you see, if serum creatinine is very high, it usually means that renal function is low, and then they have that kind of inversely proportional relationship there, right? Well, what you might find is that someone who has less muscle mass, they may not be producing as much creatinine, so you may be over here essentially, maybe shifting this over to the left, where you think they have better renal function than they really do, when that's not necessarily the case. And so basically, it's one of those things where, again, if I see someone who's like 90 years old and their creatinine's 0.8, and a normal is like 0.8 to 1.2, I know their kidney function is not that great. I just know that because they're 90 years old. So I have to assume, okay, well, let me at least adjust it a little bit to make sure I'm not going to be quite so aggressive with my dosing, because they may not be able to handle that essentially. So hopefully that makes some sense. If not, I can try to go over it a different way. Let's see what else. All right, I'm kind of running a little bit long here, I think, but that's okay. So I don't see any other questions in the chat, so let's get into talking about the pediatrics. So this is what I do when I am working clinically. Is I work at Nemours Children's Hospital. At first, I was working in the ER there for a couple of years, and then eventually I moved into a management position. Then I realized I hate management positions, and then I moved into teaching full-time. But fortunately, and this is a really great thing about NSU, which you may not find at every PA program out there, but we get to work clinically one day a week, right? We get a professional day essentially. Not to say that all your professors are professional. I am definitely a good example of one that is not, but we get to work clinically, which is nice. So we get to see real life stuff and then bring it back to you guys from week to week. Like hopefully you've noticed with some of the examples I brought up already. But anyway, so I do pediatrics mainly. So now I work as a clinical pharmacist over at Nemours Children's Hospital. And so this is something I never saw myself doing. But when you need a job, it's kind of like, okay, well, I'll go work at a peds ER. I've never thought about doing that, but let's do it. But it's a pretty fun place to work for a lot of reasons. Not only is it because kids are, kind of fun, but also it's really just neat to see like just how sick some of these kids can get and to see how well they can bounce back, especially from like an ER standpoint. You can see kids who are like, man, if an adult did that, like they'd be goners. But a lot of these kids have such reserves that it's crazy to see what they'll bounce back from. But one of the things you want to know, and you'll hear this a lot too with pediatrics, is they're not just little adults. They are quite different from a number of different ways from adult patients, and so you want to take that into account when you're actually dealing with these patients here. Oh, and the other cool things too about working clinically in town too is that we get to work with a lot of our graduates. I think like out of the surgery department at Nemours, I think they have like 10 or 11 PAs, and I think like I taught 8 of them when they were in school. So it's kind of nice to see you guys kind of grow up and become huge successes in your own rights too. But regardless, so getting into this, pediatrics is super heterogeneous. And so what I mean by that is that dealing with a 26-week gestation age premature infant is much different than dealing with a full-term infant, which is much different than dealing with a 2-year-old, which is different than a 16-year-old. They're so different, and you have to understand sort of the physiologic changes that are occurring along with that. And you can find patients from day to day can even alter their ability to handle and process drugs. And not only that too, but it's hard to do studies in pediatric patients, especially from a pharmacologic standpoint, because they were one of these really protected groups, right? It's like pregnant patients and prisoners and children. They are particularly at risk for things like drug interactions and ethical issues. So that's why there's not as much studies done in them. And so you have limited data. And sometimes we are using data that's extrapolated from adults back to the peds patients when we may not, or we may know that it's not going to be a one-to-one sort of extrapolation. So that can be a challenge. So I don't know how much pediatric stuff you've gotten into so far, but just to make sure we're all on the same page here. When I'm talking about gestational age, that's basically their maturity at birth, and so it's sort of based on the dates of like the last menstrual period and on the physical exam. And then once they are born, that's their postnatal age or their chronological age, right? And then sometimes you may use the term post-conceptional, where you're looking at both gestational and postnatal, but this one doesn't come up as often for drugs. We frequently will use gestational age and then the postnatal age, oftentimes at the same time, to get a feel for how we're going to be dosing a particular patient. And so preterm is really anything less than 37 weeks. It's rare if you see anyone under 24 weeks. That's pretty much the lower limit in terms of viability for a fetus. But sometimes we'll get 24 weekers, 25 weekers being transferred into us, and we'll talk about some of those changes that occur when they are born so premature. But anything less than 37 is preterm. Full terms like 37 to 42-ish, and then post terms anything greater than that. When I'm referring to a neonate or a newborn, that's referring to that first 28 days of life, that first month of life for them. And then infants are really that first year. Sometimes you'll hear people refer to a newborn as an infant. So all newborns are infants, but not all infants are newborns, if that makes sense. So you may hear me use the term interchangeably, but if I say neonate or newborn, that's really referring to that first month. And again, it doesn't mean that if you have a kid who's in the NICU and they turn 1 month old, they kick them out and they say, okay, go get a job now. It's more so that you can have kids that are, I've had kids that are almost hitting their 1 year birthday and they're still in the NICU, depending on how sick and how much care they actually need there. But those are the definitions, right? So then getting into toddlers is kind of like your 12 to 24 month range, young child 2 to 5, older child 6 to 12, and then adolescents like 13 to 17. I'm not going to ask you specifically, what are these breakout points. I would definitely want you to know what a neonate is versus an infant. That's a good point to know just in general. But some of these you may find are a little more nebulous in terms of changes here. And again, the older they get and the closer they are to adulthood, the less volatility there is in terms of their changes in their pharmacokinetics and dynamics and whatnot, as you'll see here as we go forward. So here's some of the things I want to look at. We're going to look at changes in mostly the kinetic factors here, as we'll see. So we're going to look at things like changes in the skin, look at things like renal function, GI function. Their distribution is different. We'll talk about neonates and infants tend to be little bags of water, as we'll talk about in a little bit, and then also changes like in CYP enzyme capacity. We'll see here in just a little bit. So these are things I'll focus on as we go forward. So getting into absorption. So again, we talked about absorption is really a factor of things like the molecular weight and particle size of the molecule. The smaller these are, the easier they can cross membranes. Also going to depend on, as I mentioned before, pH and pKa. I'm sure you are super happy to hear that come back up again. And then even the dosage form can play a role here, right? And then we'll talk a lot about changes in terms of routes of administration as well. And so again, those anatomical characteristics at the site of absorption can vary depending on the age of the child that you're dealing with. So first off, let's talk about gastric absorption, because again, this is the most common route you're going to give the majority of medications here. But the two major determinants of GI absorption for medications includes the gastric acidity and then the gastric intestine emptying time. Sometimes you see GIT or gastrointestinal time. And so basically this is referring to how quickly things are moving through the GI tract. Gastric acidity, we know that already what that is in terms of how much hydrogen ions are pumping out in the stomach and getting that pH down. And we'll see this differs pretty greatly between infants to adults. So what you end up finding is that in terms of pH-dependent passive diffusion, so that's kind of going back to that Henderson-Hasselbalch equation we were talking about before, you just tend to see pH is going to be up in preterm infants. The more preterm they are, again, they were meant to stay in the womb for longer, right? They're meant to stay in there till 38 weeks or so, and so their GI tract isn't really developed yet to start to pump out all that acid because they didn't need it before. They weren't digesting anything. And so you're going to find that gastric acid production will go up with gestational age. As the closer they get to full term, the more so they're going to be producing that gastric acid. And so you may find that initially gastric acid, or the pH is like 6 to 8 in a full-term infant. And what's interesting here is, why is it 6 to 8, do you think? Well, it's because, one, they weren't producing a lot of acid, but also because they were actually swallowing passively amniotic fluid, which is neutralizing a lot of that. So within 1 to 3 days or so, you're going to see that start to drop back down as they start to produce more acid. Again, this will go quicker with a full-term infant than like a neonate would, or than a preterm neonate would. And then going down, you're going to see that, we're going to find highest acid content between 1 to 10 days. It starts to pick back up, and it'll start to lower back down somewhat to get to kind of normal adult levels at around 3 months or so. And so what is that going to do for us, though? Right? What's the practical point here? Is that with those acidic drugs, because they're going to be in a more basic medium, they're going to have an increased ionization state. So that's going to impair absorption. So not use a whole lot of aspirin in neonates, but if you were to use aspirin, you'd find that it would have decreased absorption, right? So it's not going to work as well because less of it's getting into the system. as opposed to basic drugs, they're having an easier time being absorbed. And this is why you're going to see, if you look in like Lexicomp and you look at those different dosing strategies, they'll have like a neonatal dosing section, they'll have a pediatric, and then the adult. That's the difference. They're taking into account all these physiologic changes for these particular patients here. So the gastrointestinal emptying time, or GIT, you'll see it sometimes referred to, will determine that rate of absorption. And so you're going to find that GIT is much shorter in infants less than 6 months of age. What does that mean? Basically, they're expelling things much more quickly through the GI tract, such that there's less contact time. So if the drug's not in contact with the GI tract for as long, less chance for it getting absorbed there. And again, if you look at the number of bowel movements that like an infant's having versus say an older child, they can find like 6 to 8 bowel movements in a day, right? You can change a lot of poopy diapers when you have an infant there. And so that can then mean that you have less drug absorption going on at that point. Also talk about rectal administration just a little bit. But this can be associated with many factors, so things like type of feeding, whether they're breastfed or formula fed, can have a big impact on this. And also looking at that gestational age. The more full term they were, the more likely they are to pass things through at a normal rate, as opposed to a premature infant that maybe not has developed that GI tract. But a really interesting one here too is this congenital heart disease. You tend to find that the heart is trying to pump things. If it's going to pump blood to any two organs, it's going to be to the heart and the head, right? Other things can take a back seat. And so kids with congenital heart issues are going to have decreased blood flow to the GI tract. If you have less blood flow going to it, you're going to have a slower GIT. So you're going to find that that gets slower because they're not able to have as much activity, because there's just not as much blood flow going to the GI tract there. So all these things that you can find can play a role in terms of that GIT. So Erin said, I don't know what she's trying to say there, but maybe she had a typo. But so anyway, so with the shorter transit time, again, it's decreasing the duration of contact with absorptive surfaces. And so you could try using something like an extended release formulation that is supposed to say release over 12 or 24 hours. But if it gets expelled before that 12 or 24 hours is up, and then you're not going to get the full absorption there. And so this is why you may find that you can have intra-patient variation in terms of serum concentrations, because you may find that they are absorbing, from baby to baby, absorbing things better or worse. So let's see. Sorry, my cat's demanding attention by stomping on my computer. That's okay. If my 2-year-old's in here, she'd be doing the same thing. So we have a lot of fake keyboards around that I let her slam on. So let's look at extraoral drug absorption. So we're looking at a few things. So other than the oral route, we're going to look at things like muscular blood flow. We're going to look at mucosal permeability and then skin permeability. We'll look at this and these differences here in more detail in just a moment. So let's talk about intramuscular absorption. So let's say we didn't want to use the GI tract. We don't want to use IV. Let's go ahead and try to use the IM route, because another thing you'll find too is that getting an IV for an infant can be particularly difficult because their veins are very small, they're very delicate, so it can be tough. So if you could, maybe do an intramuscular injection instead, right? And so this can be tough too, because basically you're counting on blood perfusing the area and that picking up the drug from the surrounding muscle and then delivering it to the rest of the body, okay? There's several changes that happen in infants that can make this more difficult. So for instance, if you imagine a baby that is first born, they're not up and moving around and doing a lot of stuff. They're kind of like little just blobs, right? So they don't really do a lot of movement. Usually they're in a little burrito, not moving around much. So there's not a ton of blood flow going to the muscles initially. Not only that, their kinetics are such that they have a lot of extra body water, bigger percentage of body water as compared to, say, older children. So when I say they're like a big bag of water, this is what I'm talking about. So a lot of times we're going to have an increased volume distribution, or sort of an increased apparent volume that drug is being put into. So less muscle movement, less blood flow to the muscles means, in a bigger volume, means you're not going to be picking up as much drug, so you can slow down the absorption. You'll still have the same amount of absorption because the drug is there in the muscle. It's just going to slow it down. Not only that, but they also have a lot of peripheral vasomotor instability, meaning they can't regulate their temperature, which is why I got to have them bundled up like a burrito and put a hat on them, because they can't control their temperature as well. And so that has a lot to role to play with in terms of their blood vessels dilating and constricting to control that. In terms of rectal administration, you're going to see pretty good bioavailability here because of the fact that it's a very thin mucous membrane, very highly vascularized, and so you're going to find that you can get drugs absorbed pretty well. The downside, though, is you're going to have a lot of increased amplitude of rectal contractions. So, as I mentioned, the GIT is much shorter for these young ones, and such that they're going to have a lot of rectal contractions, a lot of bowel movements, and so sometimes you'll have patients who are, say the kid has a fever, and the parents are trying to give them a Tylenol suppository, and then later on they go to change a diaper and realize that the suppository is melted there in the diaper because the kid had expelled it. Sometimes you got to stick it in, shut their cheeks for a little bit, give it time for the suppository to melt to allow it for it to actually absorb in the first place. So little things to think about when you're giving meds to these little guys and girls. Looking at intraosseous absorption, this is a really good one if you don't have IV access, or if you need access really quickly and don't have time to wait for an IV. So I mentioned this previously, but this is basically where you're using some sort of drilling type device usually to get down into the marrow, or basically this is a nice non-compressible vein. And so this is handy in emergent situations where I need to give fluids or epinephrine or whatever the case may be to make sure that we can go and get the meds in without worrying about blowing a vein or something like that. So this is a very handy tool you'll see used a lot in pediatric emergencies. Looking at percutaneous absorption, so this is things through the skin. One of the things you're going to find with pediatric patients is that they're very thin skin. They really can't handle any criticism whatsoever. I'm just kidding. But the skin is quite thin, such that you get much better absorption than you might find with an adult patient or even a child. Basically, the stratum corneum is going to be much thinner, and if you recall, when we were talking about Fick's law, as you had a more thin membrane, you got better flux going through there, right? So kind of that example of like your armpit versus the sole of your feet, for instance. These kids have very thin skin, such that you can have drugs translocate across the skin very easily. So as an example, we don't use betadine, which is an iodine-based antiseptic, on infants anymore, because we were actually finding that iodine was causing getting absorbed very well. And what's interesting with the thyroid gland is it requires iodine to produce T3 and T4, but too much iodine actually shuts down production. So they're absorbing a ton of iodine and actually getting hypothyroidism as a result of that, right? Not only that, but the skin is really well hydrated, really well perfused, and so they can absorb things very easily. Not only that, but even covering a small area of their body is a significant amount of their BSA, or their body surface area, as compared to an adult patient. So this can result in toxicity in several instances. So you gotta be really careful. So for instance, using an antihistamine lotion like a Benadryl lotion has caused anticholinergic problems in kids. They develop seizures and tachycardia and all things like that. They used to use isopropanol, or basically isopropyl alcohol baths for these kids, and they were developing hypoglycemia and lethargy because they're actually absorbing it. Whereas, an adult patient or a child would not do that. There's one really interesting case where I think it was out in California somewhere, and basically they were having these children, they were basically testing them for maternal use of illicit substances. And they had these kids, and they all started popping positive for THC. And THC, if you don't know, is the main psychoactive component of marijuana. And so they're like, oh, the mom's been using pot all during the pregnancy. And the moms were like, no, I haven't. Like, what the heck's going on here? And so they then tested the moms. The moms were negative. They're like, well, wait a second. Like, there's no way the babies are, smoking a joint over in the nursery. So what's going on here? And what they actually found out is that one of the lotions they were using in the hospital actually had a compound in it that was cross-sensitive in that test for THC. And so the kids, their skin was so thin that it was actually absorbing that compound, and then they were popping positive for THC. So basically, the moms were not at fault here, and then they ended up switching over to a different type of a product. I think it was like a Navino product or something that was showing positive for THC, which is kind of interesting. Anyway, so getting into the distribution here. So VD relates to the amount of drug in the body to the serum concentration, right? So if you recall, our VD is equal to that dose over C0. Dose being what you're giving the patient, C0 being that initial concentration. So recall, it's a theoretical concept, right? So again, you can get a volume distribution of 400 liters. That person probably has not 400 liters of anything in their body, right? But how does VD change for these kids here? And so looking at this, we're going to see, and I'm trying to see, where is... Yeah, so we're going to see in this distribution sites here, we're going to see for these typical changes here, you're going to find a lot of total body water at very first, and then they're just going to start to dip back down. You're also going to see the extracellular water is going to be elevated as well during the first couple months of life, and then body fat percentage is actually going to go up. So they may look a little chunky when when they're first born, but it's mostly just body water. And then fat development starts to develop over time there. What does that mean for us? So, things that affect volume distribution most commonly include things like, lipid solubility. It includes things like plasma protein binding, tissue binding, and all of that. And so we can see that a lot of things can change that too. So if patients are particularly edematous, that helps more hydrophilic medications have a bigger volume to expand to, such that the VD goes up, right? Or they're dehydrated, things concentrate in, and that lowers volume distribution. And so we can see this can affect infants just as well. So with like a newborn, they're roughly 70 to 75% of body weight is just water, right? And not only that, but they have a lot greater extracellular water component. That's all that extra water is in the muscle and stuff we saw earlier. Instead of less fat tissue and less muscle tissue. So kind of think about them as a big water balloon essentially, because their VD is so much higher for hydrophilic medications. Okay, and I'll show you a few practical examples of what this looks like in a little bit. But what this means is that their bucket is much bigger as compared to the adult bucket, which is a little bit smaller. So this means that in order to get the same concentration, right, because VD is higher for hydrophilic meds in these little ones, and then for the adult patients, they have a bigger bucket, I have to give a bigger dose on a milligram per kilogram basis to get the same concentration. The total amount of drug you're giving is much smaller because you may be giving it only someone who's a few kilograms in size, but the dose you have to give, milligrams per kilogram, is going to be much higher. Okay. So what does that mean? Well, let's look at the drug called gentamicin. This is a very common one we use. It's a great aminoglycoside antibiotic we use for like gram-negative infections. We'll talk all about this next semester. But looking at this, you can see with the patient, whether it's a neonate, an infant, or adolescent, you can see the volume of distribution in terms of liters per kilogram. But what do you notice here? Okay, well, I see that in terms of volume of distribution, it's like 2 to 3 times higher than it is for an adult patient because of all that extra body water for it to go into, because gentamicin is very hydrophilic. So what does that mean for the dose that we have to give? Well, in terms of dose, I'm giving 4 to 5 milligrams per kilo per dose to get the same concentration to kill those bacteria as I would have to for an adult patient only receiving 1 to 2 milligrams per kilogram. Much bigger dose to account for the larger volume distribution to get the same concentration. Okay, so this is why when you're looking at LexiComp, you can't just take the adult dosing and extrapolate that to children, because they are quite different depending on the situation. And for highly hydrophilic medication, this is one of those situations. So not only that, but you can also find that early on they have decreased plasma proteins, which means that protein binding is going to be lower in the blood, which can also allow for things to expand out into the tissues, right, to increase that volume of distribution. Not only that, but there's some cases where we actually have endogenous compounds fighting for those same protein binding sites, right? And there's only so many to go around. So as an example of this, there's things like bilirubin that are also trying to bind for that. So there's a really good example. There's an antibiotic some of you might have heard of called ceftriaxone or Rocephin. And Rocephin you cannot use during the first month of life. And the reason for that is because it competes for the same binding sites as bilirubin. So if Rocephin tries to come in and bind to that protein, it kicks the bilirubin off. And what does that do? Well, it causes jaundice in that infant. That's why we don't use it for the first month of life. Another case here, as I mentioned, the phenytoin example, having less protein binding results ends up causing those higher free fractions, such that even though the blood levels may be the same between, say, an adult patient versus an infant, that higher free fraction means they're going to get a much more therapeutic effect and also likelihood for toxic effects. So, and just giving an example, some different ones here. You don't have to memorize any of these to any big degree. Just know that in an infant, you're going to find lower levels of serum proteins. And what does that do to the volume distribution? In general, it's going to be increasing it for things that normally would bind to that. So let's look at metabolism briefly here. Let's see what factors are going to go into this as well. So certainly we're going to see that kids that have a greater gestational age when they come out, have more time to cook in the oven, so to speak, they're going to be much more likely to have the capabilities to metabolize well versus a premature infant, right? But early on, for anyone who's born, you're going to find that their overall quantity and quality of hepatic enzymes is going to be less than a child versus an adult. Not only that, but we're also going to be looking at things like enzyme induction and inhibition, how that can play a role too. But if you recall, our phase 1 reactions are always going to be the ones that are modifying the molecule to try to make it more water soluble or get it ready for a phase 2 reaction. And this is where our CYP enzyme system comes into play under the oxidation pathway, right? And so what we're going to find is that with CYP being the most important one, you actually find that they mature at different rates in the infant, right? You're going to find that depending on which CYP enzyme you're talking about, whether it's 3A4, 2D6, all these things, they can mature at different rates. And so this can lead to some issues here. So for example, in some cases, they actually get greater than the adult levels. So here's an example of oxidation here of phenytoin, so that anti-epileptic drug. By 1 year of age, you actually have to give 2 to 5 times higher doses on a milligram per kilogram basis to a child than you would for an adult patient, right? Because they're metabolizing it so quickly. Or in some cases, you're going to find that metabolism may be slowed down. So for example, here we have things like some local anesthetics like procaine and tetracaine. They have longer half-lives because they have decreased plasma esterase activity and they can't metabolize it as well. Or something like theophylline, as I mentioned, sometimes being used for COPD. Sometimes you can use it for pediatric asthma. Has a prolonged half-life as well. So I need less drug to get the same effect because it's sticking around for longer, right? And so as I mentioned, different CYP enzymes are going to mature at different rates. So as an example, and don't memorize these because, again, I don't even have these memorized. Within a couple hours after birth, like CYP2E1 starts to increase pretty rapidly, whereas something like 3A4 are going to be present within the first month. And so frequently, this is why we have different dosing for neonates versus pediatrics based on these changes here, right? And then even within the pediatrics, you'll see it broken down into different age brackets based on some of these changes here. And then hopefully by the time they're a young infant, you may find these enzyme activities will exceed even what you would see at an adult level. So, and then with the phase 2 reactions, remember we're adding something onto the molecule to make it more water soluble. And then this is where you get like sulfations and methylations and all that good stuff. What's cool about this is that for some pathways, you may actually find that kids may have very well developed or actually really high functioning pathways here. So for example, sulfation is really well expressed in young children. And so the drug acetaminophen, right? Kids get into drugs all the time and most houses contain Tylenol. And so what's neat is like if I'm working at the poison center and someone calls me up and they say, oh, little Johnny, little Jenny, they took all this Tylenol. The actual milligram per kilogram amount that a child has to take before I send them in for treatment is higher than it would be for an adult patient. If an adult gets like 150 milligrams per kilogram or more, I'm sending them in for evaluation and possible treatment with the antidote. For a kid, I can wait until they get to 200 mg per kilo before I would send them in because that sulfation pathway is so good, right? So just as an example. Other pathways, though, may be underdeveloped, may take some time in order to mature. A really good example of this was a product called benzyl alcohol. This is actually a preservative you find in a lot of IV products, especially ones that are considered to be multi-dose, where you can actually go back in and get multiple doses out of the same vial. Basically, these kids cannot process the benzyl alcohol, and they develop a significant metabolic acidosis, and they develop this gasping syndrome. And so kids have died from this before. And this is why if you ever work in the NICU, you'll know never ever use multi-dose products, only use single-dose vials because they will not contain that benzyl alcohol, right? It's another reason why we do certain things in the NICU versus other places because of these physiologic changes. So in terms of excretion, this is another one that will be highly affected by gestational age, where the more premature a kid is, the more diminished the function in terms of, the glomeruli being functional in terms of number and size. We're going to find that renal blood flow is going to be affected by this, a lot of different factors here. And so looking at GFR in infants, what's actually interesting too is that very early on, like that first week of life, using serum creatinine is not super helpful for determining kidney function. You're like, well, why not? It's actually because serum creatinine is falsely elevated that first week of life. Well, why is that? Well, because you're actually measuring mom's serum creatinine, right? There's that equilibrium that occurs there. So they don't have a lot of muscle mass, but they can certainly have a lot of creatinine, and that's a result of the mom's blood kind of mixing with theirs. Not only that, but also you're going to see that as renal function is going to improve over the first couple weeks of life or so. But preterms, they're always going to have a diminished GFR, and it takes a long time for them to really catch back up to their full-term cohort. And so it's going to mean that you're going to have more immature quantity and quality of glomeruli, reduced renal blood flow, etc. There's a good graph here kind of showing you a term infant, which is in this dark green bar, kind of light green bar, versus preterm at various sizes. The smaller they are, the more preterm they are. And you can see here that at this rate, even by the time they're 2 weeks old, they're still not even at the same functional capacity as a full-term infant would have been at birth, right? So it does take some time for them to really catch up. By a couple of years, though, they should be at the same rate there. And so looking at GFR here, you can see that a neonate, say 1 month old, 30 to 40 mLs a minute versus as they get older, by the time they're 3 years old, they should be pretty close to adult levels there. But this is why we may have to dose things differently for these really young ones because they can't eliminate the drugs as quickly, right? So what's interesting is if you were to look at a drug like gentamicin again, we already said earlier that their distribution is altered such that neonates have to have a much higher dose on a milligram per kilogram basis, right? You have to give them a bigger dose to get the same concentrations, but they can't clear it as quickly as an adult patient was. So instead of, say, giving the drug every 8 hours or something like that, we have to give it much less frequently because their half-life is so much longer. Especially the more premature they are, the less likely they are to be able to clear that drug out. So look at the half-life differences between something like a neonate less than 1 week versus a child versus an adult patient. What does that mean practically? I think I have a graph in here somewhere. Well, basically, what this means is practically, because I didn't put in another graph here, is that for like a neonate less than 1 week, I may only give the drug every 48 hours or every 36 hours, whereas for an adult patient, I may give it every 8 hours. So I'm giving a bigger dose, but less frequent in order to allow for them to clear that drug over that longer time frame. Okay, we'll get much more into this later on, so don't worry if you don't fully grasp it yet, but this will make more sense as we cover the specific drugs later. So not only that, you're going to find that tubular secretion and reabsorption within the renal tubules is going to be both pretty well significantly decreased here. And a lot of this has to do with things like renal blood flow and things like that. So the ability for them to concentrate and secrete drugs into the renal tubules is lessened during this time frame here. So, and all of it really contributes to a lot of diversity in their drug responses. So again, not only are we going to have the actual physiologic changes that occur here, but also a lot of biological factors like, the age we mentioned, hormonal status, but also like what are their genetics, right? Are there certain genetic polymorphisms they have that are affecting their ability to metabolize things, right? Are there environmental factors that are playing a role here? Kids tend to be much more likely affected by chemical exposures like lead and things like that than older patients, and all that comes into why they're having this big variation in drug response as compared to maybe an adult patient. So just looking at the importance of things like pharmacogenetics here, I mentioned this one previously, but it's just like that CYP2D6 enzyme polymorphism that occurs in certain patients. And so again, you can find that looking at the CYP2D6, it converts codeine over to the active form of morphine, right? So this means that you could see that with the mother, maybe she is more developed than CYP2D6. If she was taking codeine and sending it to the child via breastfeeding, they may have a more exaggerated response to that because they're converting it a lot to morphine and then giving it to the child. But here you can find that the child itself may have exaggerated responses if they are hyper-metabolizing it and performing a ton of morphine, or you may find that children who have low activity of CYP2D6 are very slow at metabolizing it and don't produce very much, and so it doesn't really work on their pain very well, right? And so this is why it's got a black box warning. We got rid of codeine because we just don't know who's going to respond well and who's not going to respond, who's going to respond too well to it, and said it's just not even worth it, right? It's just too much of a gamble in terms of who we're going to give it to, right? But I think I'm going to go ahead and cut it here. I don't have too many slides left, but let me see. Yeah, I don't have too many slides left, but I don't want to rush it here. We can pick up back with this next time. Do you guys have any questions that I can answer based off what we covered before I talk more about different drug dosing strategies later on? Let me look at the sticky board here. Okay, so someone asks, will we be learning more about herbal treatments and their effects? I know it's not always appropriate to prescribe, but many patients turn to these alternative forms, and I would like to know the effect, negative or positive, on the patient as a provider. It's a very good question. So we will not spend an inordinate amount of time talking about herbal supplements. I will talk about them as they come up in terms of affecting prescription medications, right? So for instance, like a popular herbal supplement for depression is St. John's wort. And I'll talk a lot about St. John's wort and how it can affect other medications, and also how St. John's wort affects other antidepressant drugs that patients may be taking, right? And they may not tell you they're taking St. John's wort, right? That's one way. You'll also have a CAM class, which is complementary medicine course, and you'll run across a lot of herbal talk there. So I think Professor Lack is still, actually no, I think a different professor picked that class up, but that's where you're going to talk about that as well. So those certainly be places to talk about herbals more in depth. My personal stance on herbals is that they can be effective for some things. They can be detrimental for other things. And so you always want to have a very good knowledge when you're working with these different supplements in order to make informed decisions on whether to use them or not. You don't want to just say, well, just try it and see what happens. You want to have a little bit more forethought with it, just like with all the other drugs we're going to learn in Pharm 1 and 2. The other big issue you run into with herbals is the fact that you're going to find there's less quality control on them. Because they are not regulated through the FDA in the same way that drugs are, you're going to find that they are very restricted in terms of what they can say on their labels about what it treats and all kinds of things like that. But in terms of what's actually in that bottle, there's not as much control over that. So this is why sometimes patients can even get between batches or between different brands dramatic differences in effect, both positive and negative. And so that's why it can be really tough. And so that's why I always recommend really going with a consistent brand. Don't buy the bottom basement stuff, the stuff on the bottom of the shelf or out of the back of someone's car. Spend a little extra money to get a good quality product because they're more likely to have what it says actually in there. But see, Shelby said PubMed has articles on different herbals, etc., like cinnamon and for BG control, blood glucose control. Yeah, that's great. There is some other databases out there. I may try to find some and send you some information on that on Canvas. If I don't do that, just remind me. But yeah, that's probably the extent that we'll get into it. So I don't want to encourage anyone to be like, oh, herbals are dumb, they don't work. But that's a silly mindset to have there. You want to keep an open mind because some of them do work really well for stuff, and sometimes they don't. It just depends. It's just tough, and we don't have as much kind of clinical. There's not much clinical science happening with those, right? So it's hard to do good studies to really find those differences, and it's not like we have a lot of head-to-head trials with actual prescription drugs and herbals, and it's just tough, because there's not as much data out there. So, but anyway, any other questions from you guys? If not, thank you for joining me again. Hopefully the kids were not distracting you too much with their joyous, naive views on the world, and they're just so happy just to be alive. They don't know what's really out there yet. We all know, though. Things are a bummer, but it's okay. We have pharmacology we can always come back to and enjoy. Yep, thank you. Otherwise, I will see you guys the next time, whenever that is. And you guys have a great afternoon, and I'll see you later.